Thanks for joining this webinar today, which will give more information about the rolling out of the survivorship passport to other hospitals as part of the PCSP Surpass project. Just a few things before we start. If you have any questions or comments, please use the chat. If you have questions, we will probably answer it at the end of the webinar to make sure that all information is provided. I can imagine some questions will arise during the meeting, but they might be answered in follow-up presentations. If you would like to comment, you can raise your hand in Teams, and please mute your microphone if you are not speaking to avoid any background noises. As mentioned, this webinar will be recorded, so we will share it afterwards on hl7.tv and also on the PCSP website. And if you would like to receive a link to this recording, please share or your email address in the chat of this webinar or send an email to me via info@penca.eu. And then we will send you the recordings afterwards. So just a short overview of the agenda. First of all, after this welcome, Ricardo Haupt will present the PCSP Surpass project, which one of the outcomes is the PCSP Surpass implementation kit, which I will give a little bit more information about. Then Roberta Gazzaretta will go deeper into the HL7 Fire implementation guide, followed by the quick start guide that has been developed, as well as an implementation checklist by Rhonda Facile. Gerald Gredinger will explain more about the cost prediction model tool and give a short demonstration about this. And then Ricardo Haupt will get back to us with the future of the Surpass, and we will close with a Q&A and some next steps in Xshare by me and Katrien Gronaki. So first of all, I would like to welcome Ricardo Haupt as one of the project leaders from the PCSP Surpass project to explain a bit more about the project and what was done within the project and the survivorship passport. So please, Ricardo.
Thank you, Jeroen. So you will manage the slides, is correct?
Yes.
Okay, so I think that most of you know me. So I'm a retired pediatric oncologist. I was one of the PCSP founders, and I've been involved in the development of the survivorship passport since the first project, which was the INCA project in 2011. And together with Desiree Grabo, I was, because I ended in August, the coordinator of PCSP Surpass and the leader of Work Package 4. Next slide. Okay, PCSP Surpass, briefly, this is a presentation, is a study which was started in 2021 and ended after a no-cost extension in August of this year, 2025. And the title was PCSP Studies for the Scale-Up and Implementation of the Digital Survivorship Passport to Improve People-Centered Care for Childhood Cancer Survivors. Next one. So, as I was mentioning before, this came after several projects which, starting from the INCA and the concurrent PCSP Surpass project, added each project added a little piece of to the overall platform. And today I will present what is the situation with PCSP Surpass. Next slide. There are two other already ongoing projects. One is Equal, and the other one is PCSP for Area, in which the passport will be upgraded somehow to be available also for people which was diagnosed with cancer as an adolescent or a young adult. Next one. So what is the passport? I think if you are here, you know what is it, but just to remember, is a digital document which is meant to be given to individual patients after the end of therapy. It is available in digital as well in paper form. We have a treatment summary, which is a cancer history and treatment information with different sections, as you see in the right part of this slide, and provides evidence-based, if there or expert opinion guidance on survivorship-specific long-term follow-up of post-related effects, So we link our recommendation to guidelines from the International Guidelines Organization Group or from the PanCare community. It is written and translatable in most of European languages and is certified as Class 1 medical device. Next one. So this is the overall design of the project, and just in bold you see framed in red what we were talking about. So with this project we did update the passport to version 2.0, which is mostly about interoperability and certification of medical device. What we did then, we implemented it in 6 countries across Europe. And we developed the prediction model to help healthcare decision makers to assess the suitability and cost of using the digital surpass in their context. And this will be addressed by Gerald today. And of course, disseminate our research. And this webinar is part of this activity. Next one. So these are the 6 countries highlighted in yellow, which tested the implementation, the digital implementation of the Surpass, plus other countries which contributed at different levels. And these are all the partners of the project. Next one. Okay, so of course, to make the passport interoperable and translatable in all languages, what we needed to do is just to agree and share variables, dictionaries, and content of the version. So we have a list of more than 200, almost 150 variables. We have several dictionaries for the cancer, for the cancer definition, so ICD-10 and ICCC3, excuse me, that is misspelled. There is dictionaries for cancer predisposing syndrome, chemotherapy, and radiotherapy field description. So for the previous one are all internationally approved dictionary. For radiotherapy field description, we had a Surpass specific coding system because we were not able to find any radiotherapy field description official dictionary. And then there is a care plan in which there is introduction and recommendation, general recommendation, and then specific guidelines, which are adapted to country-specific regulations. Next one. So, as I was saying, we one of the main things was transform the passport to make it interoperable. This is a nice slide given to me by Desiree, which she because we didn't know what was HL7 fire at that time. So Desiree thought that HL7 fire can be considered like a electric travel adapter. So we have data we generate from our centers, and we need to export them, but the data at the Cineca, at the platform, have a different system. So we need to have an adapter, which is HL7 Fire, so which allows the hospital to directly interact with the platform. Going to more in matter, Roberta will be more specific and better explaining than me. Next one. So here is what they call as the best, my favorite slide. So just driving you from right to left, from left to right. So we have our data from data sources, and the arrow number 1 test says that from our institutions we generate the treatment summary of the survivor, and through HL7 Fire we send the data to Cineca on the Fire server, and activate within the Cineca system. The data are moved to the PanCare Surpass platform, in which there are algorithms, certified algorithms that link the treatment summary information of specific survivor to the care plan, which is according to the risk stratification, which has been defined into the algorithm. This will define the full complete survivorship passport, which is sent back to the Cineca Fire server, and from the Cineca server is sent to back to the hospitals, being either in a structured format or in a PDF format. This slide is simplified in terms that apparently all countries had the same procedure, which was not the case exactly, but I don't think this is appropriate for today. I have another slide which is hidden, in which we see that there are, in particular, Austria had a different modality, which was linked to their interpretation, in particular their interpretation of the data protection regulation in their country. So, but in general...
Det går bra, de venter på deg. Bare gå inn, du, Emily. Jeg sitter inne.
Okay, Anneli, thank you. And the data are transferred to the clinical center. What I forgot to tell you is that somehow maybe all the data in our centers are not electronically stored in a proper way. So there is an opportunity. You can either correct, update the platform directly into the Surpass platform before generating the complete care plan, or you can, as some countries did, you can prepare a sort of interface already in your electronic medical record, manually integrate the data you have not already in a digital form and send everything to the FHIR server. From our clinic, from our institution, then in countries where this is where they are available, you can send the Surpass data to your national or regional electronic health platform, and also in this case, either in a structured format or in a PDF format. With this structure, survivor can access, based on where they live, in which country they live, they can access directly to access their electronic platform directly. They can see directly their platform, or in our country they can access the medical records at the institutions, or they can access directly the platform using a QR code which allow them to access in a secure system, in a secure way to the platform itself. So this is the general outline, and today we will, my colleagues will explain you the toolkit, how this passport can be used at your institutions. I think I'm done, Jeroen, for this. Yes.
Yes, great. Thank you, Ricardo, for this introduction into the PCSP project and in the digital HL7 FHIR environment. And I'm sure that Roberta and Ronda will explain more about this. But first, I will give a bit more information about the implementation toolkit. As Ricardo explained, the digital Surpass has been tested during the project in several countries, but one of the end goals is also to bring it out to Europe and to make sure everyone is able to use the digital Surpass or to implement it in their own country. And therefore, we have developed the PCSP implementation toolkit. And this toolkit will be available on the PENCA website to help everyone interested in implementing the digital survivorship passport. And on the PENCA website, it is combined with the PENCA follow-up replication materials to provide a one-stop to all information to implement long-term follow-up care. So the PENCA follow-up replication materials consist of more information about how to implement the PENCA follow-up care and lifestyle intervention. And then with an addition of the PCSP implementation toolkit, you can decide for yourself where you are in the process of implementing long-term follow-up care. So if you are at the beginning, you can start with the PENCA follow-up replication materials. If you have already established this, then you can continue with the PCSP implementation toolkit to implement the digital Surpass. And I will now shortly show a bit of the PENCA website on how this looks like and what can be found here. So the implementation toolkit can be found on the PENCA website, which is penca.eu. And if you are on the PENCA website, You can find the information under resources. And if you click on resources, you will see the Panca follow-up replication materials, but also the Panca Surpass implementation toolkit as of this week. So if you have visited the website before and you didn't find it yet, that is correct, but it is there now. And here you see what the implementation toolkit looks like. So there's a lot of information about the toolkit, what components are in there, what materials, also all the background information that was developed in Panca Surpass or in previous projects. For example, the recommendations for survivorship care. You can find all the recommendations for surveillance of late effects, but also the short-term recommendations for surveillance of late effects as developed within Panca Surpass. And next to this, you can also find an example of the Surpass and also plain information about survivorship care for survivors, but also for non-specialist healthcare providers. So this will lead you to the Panca plain information that can also be found on the Panca website. If you don't know this information, this provides a lot of information about the recommendations for long-term follow-up care and specific late effects in plain language that's accessible for survivors, families, but also non-specialist healthcare providers. And then next to this background information, there's a lot of information on the future implementation of the Surpass in new settings. So this is really useful if you are interested in implementing the Surpass, and this consists of several items. One of this is the ALS or ELISA requirements for the implementation of Surpass. So this provides more information about ethical, legal, information technologies and interoperability, social and economic factors that influence the implementation of the Surpass and the acceptance and sustainability for all stakeholders. And I think a nice addition to this is also the best practices and experiences from the clinics that participated in the study. So they've provided us their experiences with in this case, the ELSA requirements, and they've described more information about what influenced them or what has an impact on their implementation of the Surpass with these requirements. So these are real experiences from clinics that already have implemented the digital Surpass. So next to this, there is an item about security and privacy support measures. And in here, there's more information about the security, privacy, how the data flow of the data is. You see again the very interesting graph that Ricardo already showed to you, which I think he did a great job to explain, but you can also find it on the website to find more information. Then next to this, there's a part about use cases and information models for Surpass with actions to generate, validate, and access and update the Surpass for all healthcare professionals and survivors that are using it. And then a large item will be the HL7 FHIR implementation guide, and I'm very happy that we have Roberta and Rhonda on the webinar who can provide more information about this. So that will follow later on. Then there's also the prediction model tool, and Gerald will go deeper into this now, but this will help to assist decision makers in evaluating in what conditions the implementation of the Surpass is appropriate within a certain health system scenario. And it provides an estimation of expected costs and impact associated with the implementation of the digital Surpass. So then next to this, there's also a part for which can be useful for survivors or patient advocates, going deeper into how survivors and caretakers advocates can advocate for survivorship care and for the implementation of the digital Surpass. And then lastly, there are policy recommendations included in the implementation toolkit. Policy recommendations have been developed again also within PENCA follow-up. And just as with the implementation toolkit, to provide a complete set of policy recommendations, the new PENCA SERPAS policy recommendations are connected to the PENCA follow-up policy recommendations to be able to provide a full set of policy recommendations on the importance of long-term follow-up care in general, but also the implementation of the digital survivorship passport and why this can be important for optimal long-term follow-up care. So within this document, you will find a set of recommendations on how and why to implement long-term follow-up care, as well as the digital survivorship passport. So this was a short overview of the PENCA SERPAS implementation toolkit, which you can find on the PENCA website. And I'm sure a lot of questions of what is in there will be answered in the upcoming hour in the rest of the webinar, starting with Roberta Gazzaretta from HL7 Europe, and she will give more information about the HL7 Fire Implementation Guide. So please, Roberta.
Thank you. I'm Roberta, and I'm in-house consultant of HL7 Europe. And at HL7 Europe, I'm working to support the definition and adoption of HL7 Fire in EU project.
You're muted.
Oh,
Roberta.
sorry.
No.
Okay, so I'm Roberta from HL7 Europe, and I work as in-house consultant to support the definition and the adoption of HL7 Fire in European project. So next slide, please. Okay, so we will see together details on the PENCA SERPAS Fire Implementation Guide. So first of all, what is HL7 Fire? Fire, it's acronyms of Fast Healthcare Interoperability Resources, and it's a standard defined as next generation standard developed by HL7 with the intent to create a way to exchange healthcare information electronically, and with the aim to be able to create working system solutions that are able to solve real working clinical administrative problems at a fraction of price of the existing alternatives. In HL7 Fire, everything is a resource, so every solution is based on the concept of resource. These resources are very flexible because they have a flexible structure that allows to be adopted in any healthcare domain, and therefore that must be adapted to the specific use case by defining an implementation guide. Next, please. So what is an HL7 Fire Implementation Guide? It's a set of rules that define how HL7 resources can be used in a specific use case to solve specific problem. Each implementation guide is formed by two parts. One that is the human readable part, that is web browsable, so it's an user interface, and another part that is computable, so therefore represent all the fire resources that can be adopted to implement the solution. Okay, next please. Yeah. Within implementation guide, there is a set of artifacts that are the logical models. The models are models that are independent from the specific fire version or specific in general standard, and represent the information that must be exchanged. So with the structure and the data types. Then we have the resource profiles that represent how we customize the base fire resources for our specific use case. Then we have the extension definition, that is a special mechanism defined by HL7 to add stuff to the base resources in order to be able to manage elements that are not part of the core specification. Then we have special resources that are terminology, code system, and value set that represents, that allow to define what are the values that can be adopted to represent specific entities. This because to support interoperability, it's better, and it has recommended to use international code system, or also known as vocabularies or dictionary, as Riccardo mentioned before. So next, please. Okay, so here you have the link of the implementation guide, and then if I can, I start to share my screen to see in details okay. The content of the implementation guide. Okay. So the navigation implementation guide starts with the page in which you have an overview of the project and oh, sorry, I'm using, let's say, okay. The navigation starts with the definition of the project, so the scope and the review, and some technical details on FHIR, in the particular the version adopted and the dependency with other implementation guide defined by other HL7 initiative. Then we have a specific session that is the functional description session that provides some contextual information. In particular, we have the collaboration diagram section, in which is reported the mechanism that the Pancare Surpass project defined to allow the collaboration among all the actors that are involved in the management and in the generation of the Surpass in the 6 countries in which was involved. Then we have a sequence diagram session in which is reported at the high level the interaction that occurs between all the actors that are involved in the creation of Surpass. In particular, there are 2 cases. The first one is the generation of the Surpass, the complete Surpass, and the second case is the generation only the car plan. Then for each diagram we have the indication of each interaction between the involved actors and the link to the specific logical model that represent the information that are shared in the specific interaction. Then we have the logical model section, in which we have the picture that Riccardo described before, and the list of all the logical models that details the information of each element. So, for example, by clicking on chemotherapy, we arrive in this page in which we have in this table the representation of the model. So we have all the elements that form the model of the chemotherapy, with information on the cardinality, on the data type, that it's a generic data type that is independent from HL7 FHIR. This is important to highlight, and a description. Another important session in this part is the mapping, because it provides how each logical model is mapped in the corresponding FHIR profiles that we defined in the guide. So it's important for the ones that are implementing the solution. So the logical model list is also available in another section of the guide, that is the artifact index. In this page we have the overall artifacts that are defined in the guide. So defined by the different type of artifacts. So as mentioned before, we have the logical model, the follow-up questionnaire, the resource profiles, the extension, value set, code system, and some example. So the structure of each page of each artifact depends on the specific artifact. Let's see, for example, the resource profile that represents the primary cancer condition. So here, this page is specific for fire. In fact, here we adopting the data type specific of fire. And we have this table that allows to see the content of the profiles. So here you can see that we have some extension. This extension represent, as mentioned before, things that we are adding to the base condition defined in fire. And where possible, for example, as here in histology, morphology, behavior, we adopted the extension defined by other international initiative defined by HR7. In other cases, for example, here for the relapse type, we had to define specific extension. Considering that the terminology aspect, for example, for the body side, as you can see here, in case in which we have to use code system, we have to use code to define a specific value of the element. We defined the so-called bindings to specific value set that we defined. So take consideration the dictionary defined indicated by Riccardo. We defined the codes that can be adopted in a specific session. For each profile, it's possible also to see a session dedicated to real example, in which it's possible to see, by clicking on each example, the narrative content that represent the narrative part of HR7 file resources, so the human readable part, so the human readable content of the resource, and also the computer processable resource that is available in XML or in JSON. The examples are also available in the artifact Excel page in the specific example list. So here, for example, we can say a very special resource type that is the bundle. Bundle is a specific type of resource that allows to manage a lot of the resources together, let's say. So this represents the bundle allow to collect a passport. So we have here the narrative content, so the narrative part of the surpass, and the XML and the JSON file. In addition, the guide provides different links. The first one is to the HR7 file specification, core specification. Then we have a specific page that allows to download all the computer processable file defined in the guide that can be used to validate resources, create resources, and so on. And then we have also a link to the GitHub, in which is possible to create is called issues to report the problem with the guide. So in case there are some errors, or there is needed to help, or so on. In GitHub, there is also a specific session in code here in example, in which it's possible to view the same example that are provided also in the guide. So, for example, here we can have the surpass, an example of surpass in PDF. Okay, so as generated by Chinica platform, and also the one that responds to the file resource that contains the surpass. In order to support the adoption of the Panker Surpass file implementation guide, we set up also in a sandbox environment that allows to see example, to test file, and also to validate resources. And here I have a video to make you see how our sandbox environment works.
Hello everyone, this is a quick video to show you the Panker Surpass Fire server that is deployed on the HL7 Europe sandbox. First, you want to go to sandbox hl7europe.eu, project servers, and then Panker Surpass project server. Once you click on it, you will see a pretty standard Happy Fire user interface that is made for the Panker Surpass project. Inside it, you will find all the resources that we already pushed. One of the most important one is obviously bundle that will have a list of examples of Panker Surpass passport that we already updated inside the sandbox and that you can also find in the implementation guide. For example, the bundle Hulafi here is one of the examples from the guide. So you can retrieve it directly in this user interface. You can see the entire content of the bundle. And if you want to get the resources from the HTTP interface and REST interface, you can always use get requests on the address that is written right here. And you will be able to access the Fire server through the REST API. So this is how you retrieve a resource. In here, if you click in bundle and go to CRUD operation, you also have the possibility to validate one of your resource. So here I will paste down an example bundle, which is also bundle Hulafe, and then you click validate once you pasted your content, and you will have the validation result. So here is the parameters with my full bundle, and then you have the list of warning and information that comes with this example. Again, if you want to do that using the REST API, you can use the request as described here with a body that resembles this with the appropriate parameters. Apart from the full bundles that we pushed inside the sandbox, we also pushed some of the resources as individual resources. For example, if I go here to patients and I search for patients inside the server, I will be able to retrieve, for example, the patient Hulafe here, which is basically the patient that is the subject of the Hulafe bundle that we've seen earlier, and we can retrieve all the resources as individual resources and play with them as such as well. Thank you all for your attention, and do not hesitate to use this sandbox to try things with your examples and validations and stuff like that.
Thank you. That's all from our side.
Thank you, Roberta, for this interesting insight in the HL7 Fire. I will just start sharing my screen again. Yes, and then I would like now to invite Rhonda Facil, project manager from HL7 Europe, to give more information about the quick start guide and the checklists for the implementation of HL7 Fire.
Sure. Thank you very much, Jerome. So quickly, who am I? I'm a project manager consultant with HL7 Europe. I have over 30 years of clinical research and standards development experience. I've worked in a lot of different settings, both in the United States and abroad. And what I do at HL7 is I support operations, project management, and communications. And there's the link to my LinkedIn page if you want to learn more about me. Next slide, please. Okay, so about the Quick Start Guide. So this is a relatively new idea, I think, within HL7 Europe. And the idea here is to assist healthcare providers to begin the process of adopting the Pancare Surpass Fire Implementation Guide. This is the first time that we've done this. And what's included in this document, and this is an appendix to Jerome's toolkit, it's part of the deliverable 6.5, is it contains an overview of the fire IG that Roberta just explained, and also explains what kind of, what the guide actually includes. So there's the context-specific information for implementing the guide, and it's meant to assist you or the healthcare provider IT team to begin implementing the IG to generate the Surpass. Next slide, please. And so here's a screenshot of the table of contents, and it contains some really basic information for people who've never implemented FIRE before. So what is an IG? Some of what Roberta just covered. Why do we need one? What types of data does the FIRE IG help to extract? What is in it? What technical information is needed? Examples. There's a lot of examples in this guide. There's coding examples. And then we have a section on implementation workflow diagrams that kind of help to kind of graphically crystallize, how the implementation should work and how the system should work. And it comes from the two scenarios we focused on were electronic health system at hospitals and also the clinical workflow integration and its considerations. There's also a section on barriers and facilitators, and I think we pulled a lot of that from some previous work that's been done within the Pancare Surpass Consortia, and we've included those to try to help to provide suggestions to implementers on how to get around obstacles. There's also some implementation resources, links, things to go to and things to look at, and also pointing to the sandbox and some of the tools that the HL7 Europe facilities has within it. And then there's examples of the survivorship passport, and Roberta showed you one a moment ago, a glossary of terms, because there is a ton of abbreviations and different ways of expressing things within the FIRE ecosystem. Some articles in there where, but there's a reference list of things you can go look at, and there's a lot of articles that have been generated by the Pancare Surpass Consortia that could be useful. And then finally there's an appendix A, and it contains the logical model for chemotherapy and radiotherapy. So taken all together, I think it's a pretty good start. And hopefully people will use it and we'll get feedback on it. We'll be able to make it even better as time goes on and as we learn and things change, because one thing about standards and specifications is things are always changing because the technology changes and the needs change. Next slide, please. Okay, and this one is about the checklist. And on the left there, you see a screenshot of a book by Atul Gawande, and it was published in 2009, and it was focused on the creation of checklists specifically for surgery. Gawande was a general and endocrine surgeon, and so he noticed that there was some issues going on within some of the surgeries that were being performed, and he created a checklist. And what he noted is that as a result of having a checklist, there was reduced complications and death that were happening. And so this is kind of a new book when it came out at this time. I think there's been a lot of other work on this as well. But generally, Gawande argues that checklists enhance skill. So I was thinking about this because I was introduced to the book a number of years ago, and I thought, yeah, this would be a good thing to share with this group and to think about why don't we create some sort of a high-level checklist to help people when they're implementing HL7 FIRE for the first time, or even if they've done it multiple times. And so that's what we've done. This is our first iteration of creating such a checklist. And the idea here is that, we want to help them to take the right steps in order to implement FIRE. It's a team effort. No one person can do it. You all know this. Clinicians, healthcare data, IT specialists, software vendors, and others as well are involved in the implementation. And it requires a well-structured plan. So the checklist is meant to be a starting point. It doesn't cover everything. It's pretty high level. We don't want to overwhelm, but we also want to provide some sort of mentoring to help them to develop a plan for adopting the Pancare Surpass FIRE IG and being able to generate that critically important surpass. Next slide, please. So this is the implementation phases that we focused on, and I think this is pretty high level, and most processes to do an implementation go through this. It's the planning and preparation, the technical implementation, testing and training, the go live and monitoring, and then maintenance and compliance, the regulatory piece. And as you can see there, it includes a couple of different feedback loops, as they go through the process. And more things will come up during the maintenance and compliance phase that might result changes to the technical spec. And then again, testing and training, because that is the nature of this type of work. Next slide, please. So this is a build slide. So this is just some screenshots of what the checklist contains. So here you have the preparation and planning part. It's the scoping, defining what it is you're trying to achieve, assembling a project team and including the right people in it, starting with the clinicians to make sure that we get that right, and then expanding that out to the IT staff, the vendors, compliance officers, project managers, et cetera. Assessing the current infrastructure. What do we have now and what do we need going forward in order to implement? Identifying relevant resources that could be pulled in, going back and seeing what are the guidelines, what's already in place. And then hit that again, Jerome. And then you have engaging with the EHR vendors, and this is just the first part of it. I'm not going to go through the entire checklist. And then finally there is connecting with like-minded people who are also trying to achieve an implementation of FHIR. And here I have listed Hospitals on FHIR, which is HL7 Europe's community of practice. And I think this is a really important point to build a network of people that you can talk to and gain experience from. So my next slide, which is my last, we're talking about Hospitals on FHIR. So in 2 weeks, we'll be having a meeting in Berlin. So we hope some of you might attend that event, or if not that one, ones that are going to be coming up in the fall and next year, where you can meet with people who are also implementing FHIR. So these are my slides. Thank you very much for your time and attention.
Thank you, Rhonda, for explaining the quick start guide and the checklist. I think this will be very helpful for anyone starting and thinking about implementing the digital surpass. So now I would like to invite Gerard Gredinger from the Austrian National Public Health Institute, and he will explain more about the prediction model tool on the financial costs of implementing the surpass and how this tool can be used. So please, Gerard.
Hi, thank you. So who am I? I'm Gerard. I'm here in my social role as health economist, working at the Austrian National Public Health Institute, and we were developing the so-called prediction model or prediction model tool for the implementation of the PCSP surpass. Next slide, please. So you see here the analytical or the thematic structure of the tool. What is the idea behind? The prediction model tool for the PCSP surpass should be a decision support application to enhance transparency and structure in health policy making. What we believe is that the tool supports evidence-based prioritization in health systems, and we did that by integrating cost utility analysis and multi-criteria decision analysis, which are the core parts of the tool. And what we believe it's for, it helps in assessing the feasibility and the impact of implementing the surpass within various hospital and health system contexts. And what do we get with this tool? So the tool estimates associated costs and outcomes across different scenarios in countries of the European Union. And the tool comprises 5 steps, with steps 1 to 3 forming the analytical foundations that focus on contextual assessment, data input, and the scenario configuration. And the steps 4 and 5 deliver comparative insights. So I will change to the actual tool in order to quickly guide you through. So the tool itself is an Excel file And in case you come across it, not via the toolbox that was shown to you by Jerome, there is a link you can click where you then come to the toolbox, and some further information, and the policy brief is also there that explains the tool itself and what it is for. So once you opened it, you can then start with step 1 that allows to define the implementation context by selecting the country and the hospital level digitization. And there is also some very short description of local and national digital maturity. So let's choose some country, say Belgium. So, and you can also choose which level of digitization your hospital is at. So basic digitization means that you have to do a lot by hand, for example. And advanced would mean that there are already standards like the HL7 fire standard is in place in your environment. In case of Belgium, you can't change here the environment you're in because we were following studies in order to show the level of maturity level of digitization in the environment or in the very country. And then you can choose the method of data upload, either manual or semi-automatic, in various categories. So it is starting with demographic data, and chemotherapy data, stem cell data, and so on. And this influences the costs of implementing the infrastructure as well as operating the surplus. Then you can choose whether you want to or not reference it in your local or national EHR. And then you can state the numbers of child cancer survivors treated in your hospital or whatever system you want to implement it. And the share of CCS who received chemotherapy, radiotherapy, stem cell transplantation. And the default here is taken from the 6 study sites, unweighted, so it's just an average. And then you also state the share of male cancer survivors, share of cancer survivors below the age of 6. And then you also can state how many cancer survivors are in usual care in a long-term follow-up program. Then you can choose the time horizon you want to have your prediction for. And now you have, for this very scenario we have just chosen here above, we have the outcomes, the surplus outcomes compared to the outcomes of the standard care. And what we can do next is, so it's the outcomes would be implementation costs, operational costs, costs for survivors, quality of life, patient activation, usefulness, empowerment, equality, and the surplus is driver for digitalization. And what we can do next is to weight this. We can assign weights to each outcome based on our preferences, and here is or using the default option, which is derived from a stakeholder survey, and these weights are within 100, so it means together within 1, so the lowest of the outcome of least interest would be then the lowest number, and the outcome of relatively highest interest would be the highest number here. And then we come to the results section. So we have a summary of the health economic evaluation, presenting the indicators quality gain, its quality adjusted life years, the incremental cost utility ratio, and the cost effectiveness threshold to assess the intervention's value compared to standard care. So, and if the incremental cost utility ratio is below this threshold, it's considered as the implementation is considered as being cost effective. But this is not the only outcome, and please also keep in mind that this cost effectiveness is only one of the outcomes out of several outcomes. And the next section gives us the outcomes always compared SERPAS versus implementation of SERPAS versus standard care. Green meaning the better outcome in this very section. And there is at the very bottom, there is an overall value score, and a higher score in relation to SERPAS in relation to standard care means either we opt for the SERPAS or for standard of care. And in most scenarios, this cost effectiveness is, the implementation is cost effective. And in all scenarios, if you have the larger outcomes, meaning the multi-criteria decision analysis behind it, it's 100%. The preferred alternative is 100% the PANCare SERPAS. That's about it. Thank you.
Thank you, Gerard, for this nice explanation of the prediction model tool. I will now invite Ricardo to give again to give an update on the future of the SERPAS.
Thank you. I share my screen. Okay, the future of SERPAS, as you know, as most of you know, during, excuse me, I'm going presentation mode. During the PANCare SERPAS project, the Sineca announced that they decided for internal reason not to step out of, in general, of any medical related issues in their activities. So they announced the intention to transfer the ownership of the results, and so the passport, intellectual property to Gaslini, in particular because of all the previous activities we have been involved in, as I mentioned before. So Sineca has said as a data processor was into the general agreement, and according to the data protection agreement, at the end of the process, they will, under request, send an Excel file with the data, or they can send you also an Oracle dump format using release 19C, which I don't even know what is it. To use the Oracle, you need to have set up in your system Oracle Enterprise, the software Oracle level enterprise, server LAOP servers, which make it compatible with Linux, Apache, Oracle, and other stuff. And mostly you need to have expert personnel who can manage this software. What happened after the news from Sineca that they wanted to step out? Of course, we were all worried about the future of the passport And as you know, for example, the Panker for AYA, adolescents and young adult, was the call for in developing projects related to adolescents and young adults was in place. We, as a Panker community, wanted to apply. So we asked the Sineca. So we allowed, for example, we allowed the Sineca. Actually, we asked the Sineca to allow Data River to apply together with Panker to the call. In the meantime, also the Italian Association of Pediatric Pharmacology was worried because we have a registry for long-term survivors, which is called the Road Surpass, in which we use the passport as an instrument to collect treatment data as well as follow-up data. So we were in the process of in the middle of this process of transformation. The major issue is related to the medical device certification. For those of you who knows about medical device certification, they are linked to the producer of the software. So because of the fact that Sineca has stepped out, automatically the certification expires with the end of the project. So mute yourself, please. Thank you. So because of that, we have agreed with Data River that we needed to start a new process for medical device certification to prepare the technical documentation in alignment with the medical device regulation. So this is in Italian, and I apologize for this. These are the scenarios we have discussed with Sineca. There are scenarios that are linked to the fact that you can either certify with class 1, which is the basic medical device, or you may consider that the passport, according to more strict interpretation of the medical device regulation, is a class 2A. So these are the things that our consultants need to address and define if we need to be class 1 or class 2. If we need to be class 2, more activities and more information is needed from the consultant sides. From Data River sides, from the activity development, these are all the activities which are listed both for class 1, and if you needed to, if we will decide it for class 2, this is more activities. And these activities are more time consuming. In general, I would say that class 1 is, in general, I would say a self-certification of your tool being a medical device. While for class 2A, you need to have everything double-checked by the certifying authorities. So this process might be very much time-consuming. So this slide was prepared by me as a planned next step, very optimistic. So since we are already working with consultants, hopefully by end of October, early November, I think that we will be able to identify if we need to apply to class 1 or to class 2A. In the meantime, we know that we need to apply, so we can start. We have already started to prepare the class 1 documentation to be sent. And in general, I would say that the process, based on the experience, on the fact that Davide Saraceno, who was in Sineca in the previous years, now he moved to Data River. Hopefully, things will be much quicker. So hopefully in a few months, let's say January next year, we might be able to be certified class 1. After that, we needed to do all the other activities that are linked to the class 2A, which, as I told you, are very much time consuming. In particular, you need to prepare to provide much more certification. So we needed to do this integration. And then this is the most worrying in terms of we can't put a deadline because we don't know what will happen. Now, and then it will start a sort of bilateral communication with the certifying authorities, in which they ask you to fix some issues and answer some specific questions. Sometimes the issues was told to me by Data River because I have already experience for medical device certification. Sometimes you receive a message saying, "Oh, you misspelled this or that," and so you fix, and then you send an answer saying, "I fixed it," and then you need to wait an answer from them saying, "Okay, I checked and indeed you have fixed it," and this answer can take weeks or sometimes months just to have this back, and so this might take really time, which unfortunately can be close to 1 year. As soon as any certification will be released, then we might have some issues with multi-language platform because, of course, we will certify the platform in English first and automatically and concurrently in Italian. Apparently now, in particular, if we will apply for Class 2A, we needed to have certified backward translation. So as we did in PanCare, it was that colleagues from each country which were using the passport translated the variables. Some variables are already translated, as I mentioned before, because there are international code for chemo, radiotherapy, and so on. But of course, blood count is easily translatable with any, and I'm sure that any backward translation will be a success. My major issue is about the recommendations for screening, which for those of you who were in the PanCare Society and those who are in the playing group in PanCare, we know that recommendations may be a little bit different based on country to country and the way you say things. So I am a little bit worried that the backward translations might raise several problems before the certification. So this is one issue we need to have in mind, but we don't know what will happen and if we will do that. Then after this, so the certification in the given language, which can be Flemish, Spanish, or Turkish, whatever, then we need to use the platform. The platform at this stage is in Italy, and so there will be, as we did already in PanCare, so PASS, we need to have bilateral agreements with the provider according to cross-border transmission of data according to GDPR. So this is the future. Hopefully, if I would, in my best wish is that by early January next year, we might be ready for Class 1 documentation. If we do agree, this is my idea, why don't we apply for Class 1? And in the meantime, we work for Class 2A. But this strategy has not been agreed yet. So I can't give you, as I say, this is optimistic. And this is why I don't want to share this information, make it official, because this is not an official agreement with Data River and with the consulting companies. I think I'm done for today with this, and I'm ready to get any answer from you.
Great, thank you, Ricardo, for this insight in the future of the Sherpas and your very short crash course in Italian. So I will quickly reshare my screen. So, and now I would like to invite Katrien Gronaki to explain a bit more about HL7 Fire and the help data Hi.
I'm not Ricardo Haupt.
No.
Sorry, wrong side.
Before
Yes.
me. Thank you, everyone. I'm Catherine Kronecki. I'm Secretary General for HL7 Europe, and my heart and soul is in standards and interoperability. I will talk to you a little bit about the bigger picture here, and the bigger picture that includes the eHealth DS, and in some ways incorporates all the discussion that we have seen here. So what we heard in the top level, we heard that there is a great tool, which is called Surpass. There is a platform, and we used FHIR to actually get data from electronic health record systems and populate the survivorship passport of the individual. Now, in the Health DS, and if you go to the next slide, I'll speak to that a little bit. So in the Health DS, we have this wonderful picture from the Commission, which says that any healthcare system that holds data about me, about you, about a childhood cancer survivor should provide the data, all the data, to the patient. And what the patient can do? Well, they can download a copy of their data. They can also introduce data from their side to the electronic health record system. And they can provide a copy of this data to another portal or app. Isn't that magnificent? Remember, when we started Pancare Surpass, I remember Ricardo saying passionately that this thing, copying the data from disparate electronic health records, pharmacy systems, radiology systems to the survivorship passport is a nightmare. It takes almost half a day, and in the end, you cannot tell how much radiotherapy, how much the patient took. The cumulative dose, which is the main concern for the long-term effects, could not be calculated well. So what can we do here? We have a project, and this project actually was behind a little bit of the idea of this webinar to get some of the data from Pancare Surpass. Next slide. Which is about expanding the European health data space to share and effectively use health data within the Health DS. And you will ask yourself, all right, and what does this have to do with the survivorship passport? What does this have to do with MDR certification? Next slide. Well, the regulation of the European health data space says, as we saw 2 slides behind, that we can share your data. And in fact, the regulation talks about 5 types of data, actually 6, if you take e-prescription and dispensation as separate. It says that if you have lab results, you should be able to download them in a computable FHIR-based format. If you have a hospital discharge report, you can get this hospital discharge report in HL7 FHIR. If you have a patient summary, you can download it in a structured form. If you have an imaging report, the same. If you have a prescription or a dispensation, the same thing. So all of these elements can be an import into the survivorship passport. And then you can have an even richer model of the survivorship passport. But the reason that we are here is slightly different. The reason we are here is that in our project, XAIR, we introduced 2 separate categories. The first one is IPS for research. And this format, which is the patient summary plus, is about having more richer data so that we can cover clinical trials. And we can also cover public health. But again, the most important thing where Pancare Surpass served as an inspiration to our work were the care plans. So what is the care plan and why is it related to the survivorship passport? Ricardo mentioned recommendations. And if I go back to what he said and make a bad layperson repetition of that work, is that there is a person that is a childhood cancer survivor. He or she gets the passport once is considered that you have 5 years after the diagnosis and you are considered quote unquote healthy. So you need to care about late effects. So the algorithms that are embedded in the Survivorship Passport platform, which are based on clinical guidelines, would give you suggestions about what to do next. So these suggestions go to your health professional who has to take into account these recommendations based on personalized risk factors and connecting them into the legal part of the health system that he operates, the requirements and what they are able to do in the health system, they would adapt these requirements, these recommendations. And this will be a personalized care plan for the cancer survivor. This information and this knowledge, and please go to the next slide, is what we are welcoming in the XR context, so that the person would be able to click the yellow button and actually get these recommendations to share and work with their health professionals, introducing them into the Survivorship Passport. Next slide. So what's next in this activity? This is an activity that will be launched in the context of XR. Already we had a first workshop in August in Medinfo. And we would like to take some of the experience of PanCare Surpass in terms of guidelines, turn them into computable guidelines, and then be able to create and customize care plans that eventually can be part either of a patient summary or a survivorship passport. Thinking of the patient summary as something more general than the survivorship passport. There are other initiatives that we are going to liaise with. One is WHO Smart Guidelines based on HL7 Fire. And the other one is computable guidelines based on HL7 Fire. These, the first and second bullet, are related, and we are still exploring those. The leader of this initiative within XR is Denmark, and Denmark has an initiative on care plans for chronic diseases. And we are interested to see how an initiative on care plans based on chronic diseases with the incorporation of computable care guidelines can be aligned with the PanCare Surpass experience. So we would like to get a team on this, and we think that the experience of PanCare Surpass would be awesome in that. So if you're interested to join us, please send me or anyone from the organizing team an email. We would love to have you be part of the next steps. Next slide. I think that's my last slide, huh? Yes. Back to you, Jaron.
Yes, thank you, Katrin, for this presentation about the extension of the Surpass and the HL7 Fire. So I think this was the last presentation. I would like now to ask you if you have any questions for any of us.
Yes, if I may.
Yes, please.
Can you hear me?
Yep.
Okay. So, Catherine, thank you. I just indicated my interest to be part of that in the chat. And I was also wondering, unfortunately, I was just had to answer the phone when Ricardo, when you in your final part of the presentation, so I might have missed something. But it's recorded anyway, right? And I can listen to it later. But my question, Ricardo, is I did see some question marks in your table, and I was also wondering, if we end up having another medical product for this, is there the possibility to integrate it into another survivorship passport platform as ours, because we will of course stick with ours, which is already integrated into the Austrian ELGA, but we need the care plan generator, the medical device. And so my question is, will there again be the possibility to, let's say, utilize exactly this component, not the whole passport platform, only the medical device? And of course, what will be the conditions and the costs for that? That would be very interesting for us, because as you know, we are sort of productive in Austria, and we need to have a solution, a perspective to a solution.
Yes, Gunther, thank you for the question. Unfortunately, I'm not the right person to answer, because I think we needed to discuss with the more technical part from Davide and Data River in general. What I know, and probably you already know also, in the PanCare for AIA project, there is part of the project is just to develop non-proprietary algorithms to generate recommendations. So I do not know, I don't have already, because the project is just started, the details of how these non-proprietary algorithms will be developed and at which level of sophistication they will reach. I think we needed to discuss, I don't know if now Data River in general and David in particular can answer to your question in more detail. But I think that on the long run, things should be in a way you are mentioning, in particular, if we are considering the European Health Data Space. This is my question somehow also to Catherine, how the passport, which is one tool, but is not the tool. So it's one tool which has been somehow successful, but of course, anybody, we are in a free world, anybody can develop its own things. So how this thing can fit into the European data space. So this, your new project, how can put together all these different things. So for Gunther, hopefully in the next few months, I think we will be able to have a more clear idea how these non-proprietary algorithms can be generated and distributed. But then the question is how this will be integrated in the European Health Data Space.
Yeah, I think this is great. Thank you, Gunther, for raising the question, and thank you, Ricardo, for your answer. What I hear is that you are interested in integrating the survivorship passport into the European health data space. And we have some early indications of that on the way that Latvia addressed the issue, and also Gunther and the Austrians, the ELGA addressed it. So what they did is they said that this is a discharge report. So they appended the survivorship passport into a discharge report. So this is something that we could explore in the context of the European health data space. The other opportunity that I see extremely important also, and we should start elaborating on that very quickly, maybe in collaboration with PanCare and Gaslini, and perhaps also Gunther's team, is the idea of a collaboration between what's the name of the project? I4I? The Surpass for I, is that the right name?
For AIA, something for AIA.
Yeah.
For adult and young, yeah.
Yeah, for the young
PanCare for AIA.
Yeah, PanCare for AIA.
Yeah, so we could explore a collaboration there, so we can actually have a joint result between Exer and I4I, because what we will be proposing to the HFDS is a new priority data category. So this will answer your question and about how the survivorship passport and the recommendations fit with the European health data space. It will be a formal recommendation from Exer, which is its main task, and for your project, which and PanCare, who are dealing with the specific topic in the context of cancer survivors.
Let me only just one sentence to be correct. We didn't map it on the discharge letter. We mapped it on an outpatient report template. So that's slightly different, but the outpatient, it's a 3D CDA level 3, full coded, and only the outpatient report gave us the flexibility to also include the care plan.
Yes,
and all the other elements.
But the fact is that the discharge report, priority data category in the HFDS, is the closest to the outpatient report or the encounter report. The other do not fit. It's IPS, no. It's laboratory, no. It's prescription dispensation, no. It's imaging results, no. So the only one that we can hook up in the current regulation is the discharge report, which we can somehow use in the outpatient context as well. Yeah.
I have a question in general in particular, I don't know to whom, probably Gunther and Roberta. So when you make this prediction model and you make cost estimation and so on, the experience we had in PanCare Surpass was that there are many enthusiastic clinicians and very many skeptical IT people. And so how much of this effort that you, Catherine and others have mentioned, how much resources of IT people should each institution or country put into this? Because in my understanding, in my view, I think clinicians are very much and survivors are very much interested in developing the passport. But then there is the IT part, which is, I mean, not everybody is like Gunther, very well involved in this. At least in my country and in other countries, I saw that the IT involvement is difficult. I was in one Hospitals on Fire meeting in Brussels, and indeed I found several IT people interested. But do we have, let's put the question in another way, do we have a strategy how to address this? Because at least in Italy, we don't have a national electronic medical record. In my city, maybe we have 15 electronic medical records in 15 hospitals, and the number in Italy is huge. So the workload for the IT part, in particular in country not well organized like Austria is in these days, how can be solved?
I don't know, Gerald, can you give us some insights from your prediction model? I'd like to answer, but I think you have some data, right, from the 6 clinics that implement it.
Yes, and what we did, we made them like ideal types. And what we try to do is to map it according to what maturity level they started at the hospital level and what they then wanted to achieve. And then we additionally to that, we did not distinguish between national or regional electronic health record. We said, well, price-wise for us it was the same. No difference if it's national or regional, because we assumed that they would have to make the same effort for each of it. But I would have to check of how small we went, so to which part down.
Do you have an indication of the resources required, like person months did they give us, or amounts of subcontracting?
We have hours. We have it in hours. Hours worked for every task.
And do you remember like a ballpoint of how much that was? Was it like 6 months or 3 months?
It was. I really have to check. I have to. But I can let you know. Yes, by latest tomorrow.
Thank you. And if anybody is interested, maybe they can.
Yes, just come up to
drop
me
us an
with your
email and we
questions
can provide this answer.
Yes.
Gunther.
Great.
Yeah. So what I think is that so far we were more or less, so the Banca Surpass project, we pushed towards interoperability, HL7 Fire and so on. And now we need the national health systems and Europe to catch up in terms of, let's say, the interoperability. And so the EHDS and the European Exchange format that you mentioned, Catherine, that's a perfect, let's say, if that all is up and running, we have a much easier way of tapping into the data sources. So I think the critical issue, as you mentioned, Catherine, 4 hours to collect the data for the survivorship passport is just not doable. I mean, this will not happen, I guess, in practice. So we really need to find ways to tap into the patient summary, the discharge letters, and so on, in order to compile the survivorship passport mostly from sources that we have already. So I would bet on trying to align the whole survivorship passport agenda as much as we can with the EHDS and the European developments. That's the way to go.
I actually agree with that. And I would like to take the opportunity also to congratulate your team, because you got the silver label in the recent IHC Connectathon, where we tested some of these extractions. And indeed, I think it makes sense to do this restructuring, so to speak, so that we align to the leading policy, because the FDS mandates today that by 2027, all electronic health record systems will have the capability to provide data. So according to the regulation, there is the interoperability component and the logging component, which essentially implement what we showed in my slide. They implement the ability to extract patient summaries, medication, lab results, imaging results, and discharge reports. So this is a great opportunity for integration. Where I think, however, we can make a difference together is on the part of the risk factors. Being able to identify the risk factors and from there drive the recommendations. And that would require computable guidelines and an engine that does that. But Ricardo, please. You are muted.
Just information on my experience when dealing with policymakers, administrators at the National Health System Ministry of Health. One of the issues when we are dealing national-based things, stuff like that, is that these internationally approved guidelines, so the one we are using, the International Guidelines Harmonization Group, are guidelines from a group. But if you look for recommendation for breast cancer screening in bone marrow transplanted patient, then you will have a bunch of guidelines, one from the bone marrow transplant community, one from the radiotherapist community, one from the JACA. So what the Ministry of Health administrator told me, that they, as a health ministry, they can't enforce guidelines, for example, from IGRG, unless they are not delivered from the National Institute of Health of that given country. So they say, we appreciate your work, what you are doing. We believe that your work is fantastic, but I can't guarantee that I will put my stamp on this type of recommendation, particularly when you go to some sort of, when people is taken to court. You did not do this because you did that, or why you did this, you know. So from the political point of view, sometimes it might be difficult to define why we select the International Guidelines Harmonization Group and not the one from the bone marrow transplant group, you know. So this is something that you as a IT people, you might know that we might face as a clinician when dealing with the health ministries.
And here is the magic of the HealthDS, Ricardo, or here is my hope and enthusiasm. It puts the box, it says that the patient can do things. The patient can have their data, they can have the recommendations generated from PanCare. PanCare as an association can be a third party there that can actually serve the patients, and the patients can work better with their health professional. So you may actually indirectly bypass the ministry endorsement. But Gerald, also you would like to comment.
Yes, I can give you a rough figure now for what it would cost you. It's somewhere between 1,000, well, let's 1,000 hours divided by 160. That would not even be one. That would be 2 or 3 person month, but it can go up to, in Spain we had 35 person month, and that was mainly IT people who worked on it. That was around 80% IT people. But then they were fit meeting the standards. Yeah, so it wasn't that cheap, but it still was cost effective.
And they were founded by you. So they got money from the European Commission to do the project. If you are out of the research project, this is my concern. If you are out of the research project, when the passport goes enter into the standard of care, that is a cost that somehow the health ministry has to take on. And unless it is not under a project. And this might be complex, in particular for countries with poor resources, to allow to put all that resources in each hospital with a different electronic medical record. So I think I don't have the answer. This is my concern. I am retired, so I will not see the answer for sure. But I think it's something that should be taken into consideration.
Thank you, Ricardo, for this thoughts. I think there's a lot more to discuss. Unfortunately, we have to wrap up a bit for today. So I would, if you want to have more questions, please feel free to send me an email to info@pancare.eu, and we can forward to the right person. But I would like to thank Rhonda, Ricardo, Katrien, Gerald, and Roberta for your presentations today, and I hope this is useful for anyone interested in implementing the digital Sherpas, and that will be spread out across Europe further. So thank you for today, and
thank you for setting up this very interesting webinar.
Thank you.
Bye-bye.
Thank you.
Thanks so much. Bye-bye.
Bye, everybody.
And see
Bye-bye.
some of you in Berlin. Yeah.
Fortunately, I can't make it. Bye-bye.
Bye.